Extentrac Elite, vertical protocols, foot platform, out of the way, more dynamic. He's an athlete, he's subacute. You don't put necessarily an acute patient in that position, but most acute patients get face down. Here is a film from Athens. Play the tape, please. For those acute body weight, much safer, administer the distractive force, proprioception, hands on.
Is that hands-on mobilization mostly?
Yes, sir.
Hands-on, that's for proprioception mostly, I think you're saying?
The standing is the proprioception. The hands-on is that you're supporting this, you're isolating. Yesterday or the day before, I heard a seminar where the doctor who was doing hand manipulation was saying, which would you prefer? To adjust every bone in the wrist or just the one that needs it? And when he does his adjustment, it's very, very specific. See, I wasn't just kidding when I said I got a lot out of the Parker Center. I took the classes. And same with Extentrac or flexion distraction. You're on the vertebrae localized, and then you're applying the distractive force.
And I think that's a woman doing it. Is she kind of pulling down a little bit? Is that what that's about?
No, it's more like supporting. Supporting the spinous, treating the disc underneath, feeling the amount of stretch, having the patient grab over the overhead bar, pull, so you can feel increased distractive force, and then the degree of movement that you're making. So it isolates and locates. Let's show a few more positions. You recognize this position, correct? Very important position. Pain scale 5 or above goes face down. Vertical or face down. This is the protocol 2. It's important to classify the lesion, the disc lesion. We're going to go into that quickly. But let's just show you the next slide. Please run this. All physical therapists and one chiropractor in Germany. Very serious. He's the owner of the clinic. Big clinic in Kabbalah, northern Greece. They don't fool around. They walk outside the best equipment. No compromise on equipment. So here we have the controls of these things. Precise movement. Specificity. Right? Moving, contacting. And you can do it unattended with a automatic program in there as well. It's fine. But you're seeing, she's looking at the screen, you're actually seeing exactly what force they're applying. Not just relying on patient feedback. You asked about manipulation. Under this protocol 3, when those cases clearly come into your office and you've provocative tested them, I'm going to go back and explain what that is. It's basically testing a patient to discover which position mimics the pain, and then you mimic that and you move the patient away from that position. Which aggravates the pain, and you move away from that position. And here we have actually positioning the patient in 3D. He had pain relief in extension, so he's in extension. Protocol 3. Used, I would say 10% of the disc cases come in where they clearly have relief bedding this way. That's the position you want to place them in. So you want to be able to put them on a device that has that. You could probably do it on a flexion distraction table if you have it. Maybe put a roll or a towel or pillow underneath your backs. Probably do it on VRX if you add a little arch support. We can adjust the radius of this up and down at will. Precise control for manual procedures, so you can actually feel exactly what you're administering in the angles. Exactly. And then set your automatic protocols. I like being hands-on. Truthfully, I can do an effective treatment in about 5 to 8 minutes. I'm done most of the time. I don't have to do an hour setup, an hour treatment. I think because of the synergy of positions and the synergy of movement. Everything's about movement, right? It's nothing we talked about in the seminar classes today. Movement is chiropractic, isn't it? So you're going to be moving the patient to ranges of motion under decompression, while under decompression, stretching. This is from Moscow. Run the slide, please. These are all physicians. They did not need any chiropractic support in Russia. One of the doctors is almost here. This is a very big, strong woman. She gets a whole but they're manual therapists. In Russia, the chiropractors, or the physician specialist, the gentleman is in Petersburg. He's a wonderful physician here. He's in his blue suit. After he leaves the hospital, he becomes an astronaut. Translator. So, we're jumping, yes sir.
Why was the patient's supine here?
We're going to get into that, but to answer your question, his pain, he wasn't in acute pain, and this more or less for me was a introduction to the physicians, a new group of physicians on how Extentrac worked. So after stretching, it's the ideal time. You can use the Extentrac vertical position for manual mobilization, right? And you get good osseous releases. You get good osseous releases when you're stretching in 3D or manual because you have tremendous force, precise at angles. And it's quick. By the time you're waiting for that development of a logarithmic curve that has no other clinical effect than salesmanship, the Extentrac event is over. It's almost like an adjustment. It doesn't wait to drag on to get to the distractive force. It's slow, it's graduated, but it's certain. The movement is certain. And you feel the osseous movement. And only sometimes with movement of a leg piece will you get correction of the disc or the joint into position and a movement of the potential. So while they're on the platform and prone position, you can begin to work and adjust the sacroiliac. Soft tissue. My success with these types of cases is very, very, very high now, since I've added some chiropractic procedures to distraction, 3D distraction. Of course, I'm going to stretch him with his legs maybe over to one side or the other, right? And maybe one side or the other. But I'm going to be working on these areas that are very, very important. Ask yourself when a patient comes in, where's their pain? They have sciatica, usually sacroiliac, gluteal, piriformis. You have great access with this. And the vertical position is dynamite. Really, really stretch the soft tissues. Working with the soft tissues is very, very important. Because that's what you're doing. You're working with a lot of the soft tissues. It's an actual adjustment. PI ilium. Very frequently you get a release. You go down to the lower legs, and you begin to stretch the lower legs. You do a slight impulse, and you'll get a tremendous release, right from the hip and the spine. And the patient will get well. Relatively within 2 or 3 treatments, you may be able to reduce the sciatica by 50%. Assuredly, almost every time. Particularly if you put them in prone position. If they require prone position, if they require extension position, but always with a lateral component. I'm going to go back to that. This is what I was mentioning about very important maneuver, sciatic cases, in stenosis cases. We get a lot of success with stenosis with these types of cases. And the impulse is very, very slow. It's almost imperceptible, like a toggle, like they were discussing the occiput move. Taking the traction out and just a slight impulse, right? That's chiropractic. So you have to go, right? Palmer said, right? It's not like a sledgehammer. It's quick. Quick toggle, right? Same here. Great move. After they've been stretched. More movement. Mobilizing the spine. Let me just go